I'll just have a, I'll start. So, very good evening to all of those who are present here, and hopefully more to those who will join in a little while. So, this is our penultimate session before we meet in person, and I hope that you'd have had a very productive 3 4 months learning the nitty-gritties, the basics of what allergy or allergy education can offer. We've had some great speakers, some excellent discussions over the last few months. And I've said it again and again, but I just repeat that the Rheumatology Association of Gujarat does an annual conference. This is called as the RACCon. Uh, this year, they're doing it in form of the immunoallergy conclave, and we have it in two parts. The first online section is where we have had basic discussions about various allergic disorders, and this will be followed by a case-based discussion when we meet in person. And this we have tried to keep it as practical as possible. There are workshops and case discussions of the cases that you see in your daily life, and that will help you to enter the world of allergy in case you're interested in being an allergist apart from an immunologist that you are. Uh, I welcome the chairs today. So we have Dr. Jignesh, who's a very senior immunologist and rheumatologist in the city of Rajkot. And Mohnish sir is again a rheumatologist in the city of Rajkot. So we have a Rajkot dominant panel today. Uh, Lori wishes to all of those who are present and are celebrating the festival. And Sakranti wishes to all of those who will be celebrating it tomorrow. It is the season of festivities. Most of our speakers have been international, that we've tried to keep it that domain experts who are working in the field speak on those specific topics. And often international speakers don't have the Indian idea of how allergies are different in us and how do we practice it differently as compared to what is there in the West. A lot of biologics are not available. We have different kinds of pollens or allergy situations. Adrenaline or EpiPen is not available. And to talk on all of these, we couldn't have anyone better than Neeraj sir. So I'll hand it over to Jignesh sir to continue the meeting. Jignesh sir.
Yeah. Good evening, sir. Uh, I welcome Dr. Neeraj Gupta. He is a senior pediatric allergist and intensivist from New Delhi, and he is the current chairperson of Indian Academy of Pediatric Allergy and Applied Immunology, and he is also director of diploma in pediatric allergy and asthma program. He has contributed many research papers, more than 100 research papers, nationally and internationally, and is also recognized leader in pediatric allergy education and research. I don't waste much more time because we are having a next meeting with sir in at 9 o'clock. So over to you, sir. Please welcome and give us some good talk about allergy, especially in India. Welcome, sir.
Thank you for the nice introduction, Dr. Jignesh. And I would like to thank the core person, Dr. Kunal, for giving us and setting up the platform, and simultaneously to Dr. Jignesh, Dr. Mohnish, and everybody who is present here. So I have been assigned a topic today, which is a very different topic. Uh, I will say that it is like out of the league topic, something like that, which is something an Indian lens on allergy. So this topic is not something in which I'm going to speak something about organ specific or disease specific. So in a way, it was a very challenging topic because there was nothing which was, you can say, like consolidated, compiled about this topic. But I tried to compile as much as possible with my previous experiences and my current tenure. So let's see how it goes. So first question is that why we are talking about an Indian lens today. Reason behind, because we need to really understand allergy beyond the Western templates. Dr. Kunal was just mentioning that majority of the previous speakers were from the international arena who were subject experts to that particular subject. But the Indian conditions are different, Indian patients are different, its environment is different, its ground realities are different. And that is why we need to really combine all that knowledge, whichever we have attained in past few months with the Indian lens. So it is also a journey from under recognition. So the under recognition of this specialty, I think probably few decades back, and now we are moving towards a leadership. And I will also be sharing a vision for the future. As we understand that allergy is a global disease, but with local expression. We understand that worldwide allergy affects nearly one third to nearly 40% of the population, and manifestations vary, and these can actually vary as per their geography. And we definitely require a genetic potential, and whenever a person who is atopic, and then in the presence of that, I will say the right environment, and then the modified lifestyle. So, allergy is a lifestyle disease. So, genetics plus environment plus lifestyle. So, when all these things interact together, and it is not only a simple addition, it is multiplication of that, then at that particular time, a particular person will develop allergic disease. Now, Western data will not be able to fully apply to India because we have different genetics, we have different environment. We are trying to adopt their lifestyle. That's a separate scenario. But still, we are having our older different way of lifestyle as compared to the Western people. So we definitely have all these different factors, and that's why the manifestation of the disease is different in our country. And definitely, the context matters in the diagnosis and the care. Why India needs its own perspective? Because we right now are having a massive pediatric population. Our population is considered to be the young population, somewhere 40% of the population still qualifying less than 18 years of age. We are undergoing through rapid urbanization. If I just talk about last 3 or 4 decades, so rapid urbanization is happening, and simultaneously pollution is also increasing and increasing, and it is rising to the, you can say, like every year making a new record, new peak every year. So we also have infections because of the developing country, because of the sanitation issues, because of the environmental factors, because of the climatic changes. We have infection issues, and now with the lifestyle modifications, the allergies are coming up. So we have this unique infection allergy interface. That means this balance, which is now getting more tighter and tighter in our country, and the cultural beliefs, which also influence the care. And that's why we definitely require country specific solution. The Indian allergy is a paradox because we understand that our diet, rural background, high microbial exposure, so this seems to be like something like a protective factor. But now, for past nearly 1.5 to 2 decades, or I will say last decade, especially after COVID time, we are looking for more and more cases, more and more severe cases of allergies are coming up. Number of cases have increased, severity of cases have increased. So what has actually happened? So we are moving from the protective to the destructive factors or to the provocative factors, so which we need to really understand what is happening. And definitely a lot of transition has happened, at least in one fourth or the quarter century, which has just passed, the 25 years of the 21st century, so which have just passed. So a lot of lifestyle transition which has happened. Pollution has increased, processed foods have increased, and definitely a lot of indoor allergens now they are also playing a role, and epidemiological shift is also underway. So the objective of my presentation will be that I will be tracing India's allergy journey. I will be highlighting Indian phenotypes of allergic manifestations, discuss the diagnostic and therapeutic challenges which we are facing, and I will also be presenting some Indian innovations, and I will also be envisioning the road ahead. So, the Indian allergy journey, allergy was long under recognized in India. If you just say that around 40 years back, 50 years back, this term allergy was like something like a foreign material to us. It was not considered to be very important or at all important. Initial editions of Nelson also, even in our MBBS days, MD days, allergy is never considered to be a subject. And asthma is often mislabeled as something like a recurrent cough, allergic rhinitis stabilized, food allergy considered rare, means like people used to use this food allergy word for something different meaning, could be intolerance or could be other different meaning, but not in the true sense of food allergy. And now the changes have happened, and the significant changes have happened. So I will be just sharing one video. Please watch this video, and if there is no sound, so please let me know. The story of allergy in India is one of determination, resilience, and steady progress. From its humble beginnings in the mid 20th century to today's structured programs and global collaboration, The Indian allergy journey reflects the commitment of countless clinicians, researchers, and institutions who dare to dream of a better future for children and adults living with allergic diseases. Our journey begins in 1967 when the Indian College of Allergy, Asthma and Applied Immunology, also called as ICAI, was established at the Vallabhbhai Patel Chest Institute in Delhi. This was the very first organized allergy society in India, a bold step that laid the foundation for structured clinical and academic growth in the field. It provided a much needed platform for physicians and scientists to share knowledge at a time when allergy was still poorly understood in the country. The momentum grew further in 1975 when the first national workshop on allergy, allergens, and immunotherapy was conducted at the Premier Institute. This workshop was a landmark event. It exposed Indian clinicians to the concepts of allergen testing and treatment strategies, creating awareness about an area of medicine that was still in its infancy. The next few decades were marked by slow but steady growth. Then, in 2012, another turning point arrived with the founding of the Pediatric Allergy Association of India, which later evolved into IAP Allergy and Applied Immunology chapter. This step shifted focus to children, recognizing the rising burden of allergic diseases in the pediatric population. The creation of this chapter was not just organizational progress, it was the beginning of a movement to integrate allergy care more strongly within Indian pediatrics. Education and training soon followed. The Diploma in Allergy and Asthma (DAA) was launched at Vellore in 2006, marking the first structured academic course in allergy in India. Nearly a decade later, in 2015, the Fellowship in Allergy and Clinical Immunology (FACI) began at Chennai, followed by the Diploma in Pediatric Allergy and Asthma (DPAA) at Delhi in 2020. These courses nurtured a new generation of allergists and pediatricians equipped with the knowledge and skills to diagnose, treat, and prevent allergic diseases. The establishment of such programs reflected the growing recognition of allergy as a discipline requiring specialized training. Alongside education, advances in diagnostics reshaped practice. From 2010 onwards, in vitro allergy testing with immunocap technology and component resolved diagnostics became available in India. These modern tools brought accuracy and precision, replacing older, less reliable methods and making it possible to personalize care for patients based on specific allergen sensitivities. Milestones were also captured through published works between 2019 and 2025, documenting India's contribution in research, practice, and guidelines. The academic footprint of Indian allergists grew, adding India's voice to the global allergy discourse. In 2012, India witnessed the inaugural edition of PED-Allercon, the country's flagship conference dedicated to pediatric allergy. It brought together experts, students, and practitioners to exchange ideas and foster collaboration. Over the years, PED-Allercon grew into a trusted platform. Even during the COVID-19 pandemic in 2020, the conference adapted seamlessly into a virtual format, ensuring continuity of learning. By 2025, PED-Allercon celebrates its 13th edition with representatives from 10 countries, a testament to the resilience and growth of the Indian allergy community. The Indian journey is also marked by indigenous innovations. In 2022, India introduced Epishot, the nation's first indigenous epinephrine autoinjector, which went on to win the prestigious Dyson National Award for a country where affordability and access remain critical challenges. This was a transformative step, ensuring that life-saving treatment for anaphylaxis became more accessible to patients. The pace of transformation quickened in the mid-2020s. In 2024, India achieved international recognition with the designation of 3 institutions: Sir Gangaram Hospital in Delhi, Christian Medical College in Vellore, and D.Y. Patel Hospital in Navi Mumbai as World Allergy Organization Centers of Excellence. This recognition highlighted the clinical expertise, academic leadership, and research capability of Indian institutions on the global stage. The same year also saw the expansion of training opportunities across the country, including the IAP Certified Pediatric Allergy, Asthma, and Clinical Immunology (PAAC) course, as well as Diploma in Allergy, Asthma, and Clinical Immunology (DAAI) course. These programs reflected a shift toward democratizing allergy education, making structured training accessible to more physicians nationwide. By 2025, several transformative initiatives came into being. Standardized immunotherapy, Sensimune, was introduced, bringing consistency and safety to allergy desensitization treatment in India. The Allergy Bulletin, a monthly publication by the IAP Allergy chapter, began circulating, spreading knowledge, awareness, and updates to members and practitioners. The Allergy Smart School initiative was launched to raise awareness among children, teachers, and parents, ensuring schools became safe spaces for allergic children. The year also marked efforts to strengthen professional networking and global collaboration. In 2025, IAP Allergy Chapter established dual membership with the IAKI and AIS program, enabling Indian allergists to participate more actively in European academic activities. The launch of Chapter's YouTube channel with over 2,000 subscriptions in 6 months' time period and its own website expanded digital reach, while a growing community of over 1,200 active members demonstrated the rapid expansion of allergy as a discipline in India. The Indian journey is not just about institutions and technology, it is also about regional expansion. From Delhi to Chennai, Bangalore to Nagpur, Jaipur to Kottayam, Hyderabad to Odisha, Pune to Guntur, and beyond, allergy education, workshops, and training have spread across the country between 2012 and 2025. This geographical spread reflects the growing recognition that allergy is a nationwide challenge requiring local as well as national solutions. Looking ahead, India's allergy community has articulated a clear vision 2030. The vision is ambitious yet achievable. It includes academics with structured IAP and NBE certified training programs, eventual NMC recognition of specialty as a medical specialty, and the creation of an IAP textbook of pediatric allergy, along with a dedicated pediatric allergy journal. On the scientific front, the focus is on advanced diagnostics and therapeutics, ensuring that Indian patients have access to the latest technologies and treatments available globally. Research will be strengthened through standard national guidelines, multi-centric collaborations, and well-documented clinical trials. National registries are envisioned to capture real-world data on allergic diseases, while patient support groups will provide much-needed assistance and community engagement. Importantly, the vision also emphasizes school and community education programs, extending allergy awareness beyond clinics and hospitals into everyday life. The establishment of a National Allergy Day is part of this vision, a symbolic yet powerful step to draw attention to the growing burden of allergic diseases in India. From the early beginnings at Vallabhbhai Patel Chess Institute to the global recognition of WAO Centers of Excellence, from the modest first Pet Allercon in 2012 to the grand 13th edition in 2025, from indigenous innovations like EpiShot to ambitious national visions for 2030, India's allergy journey is a story of persistence, innovation, and hope. It is the story of how a small community of committed physicians, scientists, and educators came together to transform allergy care in India, turning challenges into opportunities and aspirations into reality. And as we move forward, this journey is not just about history. It is a living, evolving story, one that continues to inspire, to grow, and to create a healthier future for generations of children and families across India. So, this was a brief video which was mentioning about the Indian journey, and definitely there were few things which have been, you can say, like not covered in this video. I would like to cover these things also. So, one thing is the major contribution by Dr. P.K. Vedantan. So, Dr. P.K. Vedantan has been really instrumental for past nearly 3 decades for spreading community education, community services, and simultaneously igniting the first formal educative program about allergy in the country. He is considered to be the pioneer to start with all the programs. And even Dr. Kunal has also started this program in 2025, late 2025, and in which you all are also participating. So what we saw that the growth of allergy actually started late as compared to the Western world, but we have witnessed a very rapid growth of allergy specialty, and especially the strong pediatric leadership has been witnessed, and with the rise of structured education and growing patient awareness, the momentum seems to be clearly visible. So it seems to be that from where we started somewhere around 2 decades back, 2.5 decades back, from negligible to now, it has now come to the national attention that we have now announced as a National Allergy Day, which is 11th October. So allergy is now considered as a mainstream issue. And now I have heard that from the National Board of Examination also, this allergy is now going to be started soon as a super specialty branch. So the announcement is coming on any day at any time. So the dedicated allergy clinics are emerging. We are now witnessing national conferences. Even in your rheumatology conference, now the theme is immunoconclave. So the chapters and the societies are now getting more and more active. Training programs are expanding, and policy attention is beginning. So the burden of allergic diseases in India: asthma prevalence is rising in children. Allergic rhinitis seems to be highly prevalent. Atopic dermatitis is increasing in urban areas, and food allergies, though now the cases are reported, but they are still underreported from different parts of the country. And definitely these are affecting the significant quality of life. And the important thing is, whenever a child is sick, whenever the child is not feeling well, then at that time the entire family suffer. If the child is unable to sleep, then even the parents are unable to sleep, their quality of life is disturbed, they are unable to do their own regular work. So actually it is a problem of the family. The quality of life of the entire family is disturbed. So this is one paper by Dr. M.T. Krishna, which was published in 2020 as an appraisal of allergic disorders in India, an urgent call for action. And it says that estimated 40 million cases of asthma are right now there in India, and there are many cases which are even not labeled as asthma. 40 to 50% of pediatric asthma cases in India are considered to be uncontrolled or severe. And the treatment is suboptimal because there are several factors, among which the important one is unaffordability to buy the medications, religious beliefs, because there are many people who are having different type of religious beliefs. They would not like to take this particular type of medicine or this particular type of investigation, or there are different type of beliefs, or this particular food to be avoided, this particular food to be taken. So different beliefs, so it becomes really difficult. There are myths and stigmas which are regarding the chronic ailment. The people feel that allergies will never, you can say, like, get treated. The people feel that asthma will be like a lifelong type of thing, so they do not get tested themselves, they do not get appropriate treatment. And then the illiteracy, which is important, and the lack of allergy specialists, which is also very important. And now this paper, which was published by Helen Brew in 2022 in Allergy, which is now depicting about the prevalence of food allergy. And if you just see the prevalence of pediatric food allergy, the more darker the color, the more red the color, the more higher the chances of prevalence. So if you just see that India is falling somewhere around 2%, 2.5% of that prevalence. Now, this majority of this prevalence is actually based upon the parental reporting or symptoms and sensitization. But OFC proven food allergy has been seen only from one single country, but rest of the others are mainly based upon the questionnaire basis, and which is also not that reliable data. So this is one paper from India, which is from Dr. P. A. Mahesh, which was published in 2023, says allergic sensitization foods in India. If you just see in vitro diagnosis, that means based upon the specific IgE. So there are many people who are having high specific IgE, high total IgE to many foods, and ultimately nearly 20%, 25%, 27% people are actually having the positive specific IgE or positive sensitization. But when they saw that actual true food allergy, that could be only on the basis of skin prick test or correlating the history or the symptoms with the test, then at that time they found that it is only 1.2% in the adults and 0.14% in the children. That means there is something which is there in the discordance, which is still there, but definitely food allergy cases are there and they are yet not reported like that. India is having different genetics, different environmental factors. I will just go a little backward in the Paleolithic era, how these allergies are developing. So, human being, if we just trace to the Paleolithic era, that means more than 10,000 BC years, then at that time, the human beings were living in small groups. They were like hunters, gatherers, scavengers. And at that time, there were several different organisms which were there inside the gut of the human being. They were living like a friend. So there was a symbiotic relationship which was happening, which is also called as old friends hypothesis. So they were like definitely helminths, saprophytes, mycobacterium, tuberculosis, hepatitis A, salmonella. So they all were like keeping a check on the allergic manifestation. So there were no allergies at that particular time. Then the first epidemiological transition happened, and the era changed from Paleolithic to Neolithic and Bronze era and Iron Age. And at that time, now the larger social groups came up, animal husbandries came up, so people started domesticating pets, and at that particular time, the microbial change happened. Now, old friends remained there, but the new intruders came. Now, the new intruders were different viruses. These viruses could be the Kelsey virus, rotavirus, coronavirus, paramyx virus, different type of viruses which came in. But because the old friends were still there and they were able to keep a still check, they were able to still keep a check on the allergies, even if the new intruders came in. But now, the second epidemiological transition, we move to the modern era, in which we move to the cities, concrete, tarmac, soap, detergent, and thanks to the COVID, everybody is now, you can say, like more and more hygienic, more and more clean, more and more soaps and detergent. And ultimately, what happened? Now the old friends have gone away. That could be helminths, toxoplasma, H. pylori, salmonella. They are going down, whereas the new intruders are remaining. So this is the disbalance which is happening. So it is not the pure hygiene hypothesis, it is basically the targeted hygiene which is mainly responsible for, you can say, like increase in the allergic manifestation which is happening. If we just see here, so in this figure, if we just see that this genetic environment Though this dark green is mainly the environmental, the microbial diversity, more diverse the microbiota than healthy environment, whereas more the urban development, changes in the lifestyle, unhealthy environment. So what is happening? If the person is having in a healthy environment, then at that particular time the immune system remains in a balanced way, and ultimately the immune homeostasis is there and there is no allergic manifestation. Whereas as we are moving towards urbanization, changes in lifestyle which is happening, so the epigenetic changes are also happening in the DNA, which is DNA methylation, and ultimately more and more inflammatory disorders are increasing. So it is not only allergy, even allergy, autoimmune disorders, all these disorders are now going to increase and increase. One more thing which I would like to say, that whenever a baby is there in womb, then at that particular time, this womb area is considered to be sterile. So the baby's immune system, developing immune system, is not challenged with any particular microbial organism. At that particular time, the immune system is shifted towards the Th2 pathway. So whenever a baby is born, then at that time, at the time of birth, his immune system is skewed towards Th2 pathway. Now, it is the humble duty of the surrounding environment, that could be the vaginal delivery, that could be, you can say, like the normal microbiota in the initial few months of life, that challenges the Th1 pathway, matures the Th1 pathway, and ultimately the Th1 and Th2, they, you can say, like balance out or even out each other, and ultimately energy is reduced. But suppose if the initial first 1 year of life or first 2 year of life, we usually say first 1,000 days of life, so that means from conception till 2 years of age, if it is extremely hygiene, then at that particular time, this Th1 pathway of a newborn baby will not get a chance to mature. And ultimately, these babies are more likely to develop or remain allergic, or their Th2 pathway remain dominant. It will not get suppressed, and ultimately the allergies will remain. So the same thing which I am saying, that a person who is born with a genetic predisposition, and ultimately depending upon the timing and the doses of the allergen, when it is exposed, and ultimately it will decide that whether the person will become tolerant or he will become allergic. So this also brings the concept about difference between urban versus rural allergy. Urban children are like more urbanization, more concrete, more hygiene, then less microbiota, less diversity in the microbiota, so more chances of allergies, higher asthma, higher rhinitis. And now even rural areas are also changing. So rural areas are also now catching up rapidly, and pollution and lifestyle are the major drivers. Hygiene, I have just told you about that, and there is a gap between prevalence and the diagnosis. The other important thing is that conventionally we have been told that allergy or allergic asthma or allergic problems, they are probably Th2 type, that means allergic pathway or non-allergic pathway. But now there are few other things which are also coming up with the gradual rise in pollution, with the gradual rise in the viral-induced diseases, viral-induced diseases. Actually, it is more and more non-eosinophilic or neutrophilic type of exacerbations of asthma phenotype is also happening. Simultaneously, poor inhaler adherence, severe asthma, often getting under-recognized, and late presentation to the specialist, all these. So this is one latest paper from 2019 about the inflammatory phenotypes of severe asthma from India, so which is saying that now there is a gradual shifting towards neutrophilic type of asthma more as compared to the previous reports. Though this paper is from the adult, but still it is saying that there is a shift from eosinophilic to the neutrophilic pathway, which seems to be more because of pollution related, more because of infection related. Allergic rhinitis, Indian reality. So majority of the time, in India, it is mostly perennial rather than seasonal. Why? Because the ambient conditions inside the home, they are actually ideal for the growth of the dust mite, and these dust mite are mainly predominantly responsible for this allergic rhinitis manifestations. Then sometimes there is an overlap between sinusitis adenitis. There is a significant impact on the sleep and learning, and if getting often treated or untreated or this thing. Now, these are the common allergens for indoor allergens, which are the dust mite and the cockroach mainly among the insect group, which are there about the, you can say, like in the bronchial asthma, rhinitis and bronchial asthma, obesity phenotype group, which are there. About the food allergy, Indian context. So food allergy is definitely lower reported prevalence than West, because in the West we just saw Dr. Helen Rowe paper. They are reported up till 7%, 8% also. But from India, they are reported up till a maximum of 1%, 1.2%, 1.5%, a maximum of 2%. So why it is like that? Are we having different feeding practices? Yes, we have different feeding practices. There are different cultures. The mothers during the pregnancy, they are given some different type of, you can say, like unrestricted diet. I will say that they are given some, if you understand in Hindi, which is called as laddu. So laddu is something which is a mixture of nuts and carbohydrate and protein and fat. So everything which is getting combined together. So these are given. And then the people are taking natural dahi, curd, all these things, so which are natural probiotics. So we are definitely having different cultural feeding. Our cooking process is also different as compared to the West. So in the West, majority of the things are roasted. Here we are, majority of the time they are either boiling or cooking, properly cooking. So these cultural practices, are they protective, or there is something else which is happening? Nowadays, we are also getting this milk, wheat, peanut as a source of allergen. But there are newer food allergens which are also identified from India. So they are not the top 8 food allergens which are conventionally considered to be the most prevalent allergens. But there are certain newer food allergens which are there in India. So I will be coming to that. And then majority of the time anaphylaxis is underdiagnosed because there is a poor documentation or no registries. So this was our paper which was published 1.5 year back, and in which what we saw, that we compared urban and the rural school children from North India, and what we found, that apart from the conventional this milk, egg, and wheat, we also found that there are people who were sensitized or who were giving the history of mango, strawberry, orange, custard apple, and banana, and even brinjal or eggplant. So brinjal is one you can say like particular vegetable which is repeatedly reported from India. But in the Western world, brinjal is never coming in the top 8 food items. So the top 8 food items, when we are talking about, it is the Western data. But from India, we definitely require studies from our side, and then only we will be able to say that what we are allergic to. Then atopic march, even the classical atopic march, what we understand, that two start with the skin manifestations come, then the respiratory manifestations, usually the rhinitis and the asthma comes. But in India, many times, many children, they wheeze first, or the rhinitis happen first, and the skin manifestations can happen later on. So it is also possible, which is also called as the reverse atopic march. It can happen. So classical sequence is not often seen. And then early wheeze is common without eczema. Even infection allergy symptoms are overlapping. Sometimes it is considered to be common cold, sometimes it is considered to be allergic cold or allergic cough or allergic symptoms. So they are overlapping. So it becomes really difficult to differentiate. And then role of microbiota, because of the you can say like the environmental conditions, because of the environmental exposure, still two-thirds of the Indian population is living in the rural areas. So because of that, there are lot many microbiota exposure which is there. So we are yet protected despite the high Ig levels, despite the high Ig producers, we are yet protected from manifesting the disease. But as the lifestyles are changing, we are definitely high Ig producers, so we have a tendency to become allergic. And as the lifestyles are changing, so we are actually adding fuel to the fire, and we are developing more and more allergic manifestations. So the air we breathe, if we just see the ideal picture, the pure air should be somewhere like a mixture of nitrogen, oxygen, argon, carbon dioxide, water vapor. But is it true? No. We are breathing something, all these things above the pure air, which is pollutants, dust, bacteria, viruses, fungi, pollens. And then there are pollutants, could be gaseous pollutants or PM particles. So the pollutants can be, or the pollution can be divided into, classified into outdoor or ambient atmospheric pollution, or indoor, which is home pollution, basically home pollution, indoor pollution. So among the indoor pollution, the biomass fuel exposure, which is very important. Then incense stick burning, mosquito coils, poor ventilation at home, major risk factors are there, and then often ignored in the history taking. So if you just see this picture, I'm sure that you must have seen this picture in Dr. Vedantan's slide previously. So this picture speaks much more than a picture. If you just see that this poor lady who is cooking the food, and definitely at least 2 times or probably 3 times in a home like this, she is cooking the food with a very poor ventilation source, and this poor chap is a small child who is just standing here. He is breathing all this smoke inside. So you can just imagine that what could be the AQI of this particular area. And the other important thing is that government has already provided the gas, and the gas is there, chula is there, but still she is using the conventional biomass fuel. So I don't know whether the gas has been provided but cylinder is not there, or whether the cylinder is also there but the knowledge has not been given, or whether the cylinder seems to be more costly as compared to the biomass fuel. But definitely this is actual India. So India's rural population, yet now it is nearly 65% of 1.4 billion still live in the rural area. And this is the picture of there. And if you just see that the average AQI of indoor is somewhere around 400, 300 to 400. Average AQI I'm talking about. Many a times in your home, in my home, modular kitchens are there. And at that particular time, the AQI, during the time of all these oil cooking with these parathas and puris, then at that time, our home AQI touches nearly 800, 900 also. So just imagine the 2 times a day, 3 times a day, our AQI, we are breathing, our children are playing there, AQI touching 800, 900. If you just see the daily average exposure to respirable particulate matter from the combustion of biomass fuels, so majority of the time, this respiratory particulate concentration is because of the wood chips and agriculture products. So these all are, or the biomass fuels, these are the major culprit of this PM particle. Now, if you just see the type of the kitchen, so these are the 4 diagrams A, B, C, D, in which the first diagram is saying indoor kitchen without partition. That means you have the kitchen inside the home and there is no partition at all. Very bad, extremely bad. If you just see that how much is the respirable PM particles. Then second diagram is showing indoor kitchen with partition, at least a little protection, but still bad. And then the third thing is kitchen outside the living room, which is important. Many a times now in the modular areas, the modern areas, the modular kitchens are actually just adjacent to the living room and they are very open to the living room. So either the first scenario or the second scenario is there in which we are living. The third scenario in which kitchen is outside the living room or living area, which is not there in the current scenario, but yes, it is there. So the PM particles are lesser. And the fourth one is just totally outside, no connection at all. Then at that time they are minimum. Burning of mosquito coil. So what are these mosquito coils? Mosquito coils, the chemical which is there to repel the mosquito is only 0.1%, which is pyrethroids, and 99.9% it is coal dust, coconut husk, binders, resins. What it does is that burning one mosquito coil produces a PM 2.5 particle equivalent to nearly 100 to 125 cigarettes. Can you just imagine? You ask from a person, anybody is smoking at home? Nobody is smoking. Very religious people just burning one agarbatti, dhupbatti, or probably as per need, mosquito coil per day in their house. And ultimately, this much type of smoke which is happening, PM particles which are there. Just see about the incense stick. What is happening with this? All these agarbattis. So it has been seen that the oxidative stress due to all these agarbatti burning and the incense stick is nearly 25 to 30 times higher as compared to the cigarette smoking. If you just see here that with the cigarette and the incense stick, ultimately it is the PM 2.5 particles which are released are 5 times higher as compared to cigarette burning. So they are 5 times more damaging as compared to cigarette burning, which is important, which we need to understand. And this is something like a hidden danger, because even if somebody who is smoking cigarette, people understand cigarette smoking is bad, but somebody who is burning incense stick, they feel that this is very safe. They are taking it like safety. So they are very happy doing that. And this is much more damaging. This is more silent killer, which is happening. So the same thing which is happening here, if we just see here, the second-hand smoke and the topi, they all are in synergism with higher odds ratio of nearly 3.77 development of allergies are there. Similarly, for food allergy, the food allergy sensitization, this is also like more odds ratio which are there if the person who is getting exposed to the second-hand smoke. Now coming to the outdoor pollution. Outdoor pollution and climate change. PM 2.5 levels are among the highest globally. We understand most polluted city considered to be Delhi. We are always number one, so we will remain number one. But this is not a good thing. This is very bad. How it is affecting? Just see. I will just tell you. Just see the most polluted cities in the world in 2024. They are like out of these 20 polluted cities, I think nearly 14 are from India, which is a real shame to us. And how it is affecting allergies? So this is one study which was published in 2010, which saw that those pregnant females who remained within 50 meters of the main road where the trucks are passing, where the heavy vehicle is going on, pollution is going on, within 50 meters, versus a second cohort in which the pregnant females are remaining more than 200 meters away from the main road, their babies, when they saw the risk of allergy and asthma developing in their babies, then at that time their babies, the odds of developing eczema and asthma are nearly 2 to 4 times in those babies to whom the mothers were remaining within close proximity to the main road or to the pollution. That means it is really troubling. There are increased risk of, you can say, like increased traffic air pollution will actually cause increased risk of asthma, sensitization to different allergens, eczema, hay fever. Second-hand smoke also increases the risk of asthma, allergic sensation, eczema, and this is commercial district within 200 meter of residence, increased risk of allergic rhinitis. So diesel exhaust particles, they increase the allergen specific Ig levels by up till 50 folds, which is very important. So pollen become more allergenic. What happens? That suppose same pollen, Holopetelia, for an example, you take Holopetelia pollen or tree from Delhi versus you take it from a rural area. So the flowering season will start earlier in the polluted area in Delhi for the same type of tree or same type of weed or same type of grass, whatsoever it is. It will start earlier. It will reach to a higher level. It will last longer. So the number or the amount or the quantum of the pollens produced are much more. The second is the pollen protein itself, the allergenic protein itself, will get nitrosylated, and ultimately because of this nitrogen free radical and the oxygen free radical, their allergenicity also increase. So both quantity as well as quality of allergenicity increases of pollens which are grown in the polluted area. Do pollutants means like cross the placenta? Yes, it has been measured that nearly 300 pollutants, they actually cross the placenta. So definitely this is more troublesome. So pollution definitely affects allergies, and in which it creates pro-inflammatory cytokines, maturation of antigen-presenting cells, expression of antigens, different methods. Ultimately, the message is that it increases the Th2 pathway, which is the method. So this is one recommendation paper from our unit in which we produced in Indian pediatrics. If you are interested, it clearly says that air pollution is the emerging contributor to respiratory allergies and children are more vulnerable. Coming to housing and lifestyle factors. So previously, our houses were, you can say like in one house, kacha pakka house, in which there are lot many kettles and pets and human and different other people which used to live together. Now what is happening, that everybody has gone separate. People have moved from the joint family to the nuclear family and now to the single family. That means single in the sense that either the people are getting, you can say like separated out and they are just living single, or so ultimately who is coming in now? So more and more modern things are coming in. Carpets are coming in, curtains are coming in, soft furnishing things are coming in, and then this is an important source of VOCs, volatile organic compounds. Overcrowding, which is also happening, especially in the slum areas. Air conditioner misuse, timely not getting filters cleaned, and then dampness and mold because of poor sunlight and ventilation, especially if you just see areas like Delhi, which is densely populated. So there will be a lot of dampness and molds which will be there. And ultimately, the allergen load, especially indoor, is underestimated. And then there are different cultural beliefs and practices in India, like fear of inhaled steroids, preference for oral medicines, faith-based and home remedies, delayed specialist referral, and need for culturally sensitive counseling. There are different Indian practices. You must have heard that food which is going through the skin is sensitizing, whereas if it is taken orally, then at that time it is tolerogenic, right? So, but when our dadis and nanis, they are doing this oil massage, coconut oil massage, or probably the mustard oil massage to the child, is it good or is it bad? How it is good? So we really don't know. So there are different Indian allergy, you can say like practices which are there. And then the fish therapy. Everybody must have heard about Hyderabad fish therapy for the treatment of asthma, whether it is good or bad. So there are different Indian practices which are happening in different part of the country, and they all are actually having influence. We really don't know the answer which is having good influence, which is having bad influence. And then infection allergy interface, in which there is a high burden of respiratory GI infections, different other infections which are there, overuse of antibiotics, and ultimately we need to really understand. So if we are becoming allergy specialists, that doesn't mean that we should tilt only, we should see only allergy. No, allergy specialist means that we need to, uh, I will say that rebalance the thing. The balance has shifted. The balance is tilting from TH1 to TH2. Our duty is to balance out the thing, to rebalance the thing. This is our duty. It is not that our duty is to treat allergy and that's all. No, we are here to, you can say like make the balance so that ultimately everything should be balanced. And then there are so many things which are underdiagnosed and mislabeled. You also understand that asthma, majority of the time it is recurrent cough. Recurrent cough, person is taking some of a nebulizer but never getting proper treatment. Then many a times even allergic rhinitis is labeled as common cold and then treated with probably some syrups and the tablets. Then many a times people are told about milk intolerance versus true allergy. So they are actually confused. Many a times they feel that it is milk allergy, but it is not milk allergy, or the vice versa, which is happening. Even the same thing happens in between the true wheat allergy versus celiac disease. They both are different, but the people use the terms interchangeably. So ultimately, the early interventions are missed. Similarly, allergy testing. So Indian challenges are that limited availability of quality extracts, non-standardized and irrational panels. People are doing, you can say, like extensive panel testing, which is wrong, which should not be done because we are less equipped, not equipped to take a good history. We are not equipped to go deeper and deeper into the history and ultimately try to identify the relevant allergens. We are just ordering in our busy OPD practice some panels and then something hazard which is coming out, and then we are trying to, you can say, like prove that okay, this test positive. Ultimately, we try to treat the test rather than the patient. And we need to really rationalize our practice. Skin prick testing, we understand that it is considered to be gold standard, but we definitely need appropriate size lens sets, equipment, extracts, and definitely training. So training is not something that me or you, somebody who has probably done half an hour, 1 hour of webinar. Training is something which is a rigorous years of practice. Then that is called as training. Like if you just see, go to US and UK. So allergy training is a 3 year super specialized in-house course. It is not something which is probably a few sessions and then we are, you can say, like trained. No, these all are the capacity building type of things, but we need to have more and more training, which is important. And that's why even Dr. Kunal was also mentioning about the physical training, which is about to happen in 2 weeks' time or 3 weeks' time. So, which is important. In vitro allergy testing, yes, it is very easily available and easily available, easily misused. So, majority of the time, the pharma guy or the laboratory person comes and he guides us or she guides us that okay, you have to do this test and this is the interpretation of that, and ultimately we go into the trap of, you can say, like the non-standardized test, so which should not be done. And then now with the advent of this component testing, people are ordering left and right component testing without understanding that what this component is. Component is something which is a very advanced test which need to be reserved for the specialist only, because there are so many things which will come positive and ultimately you will be confused. There are so many things which are likely to be missed in the components. So you need to have a good knowledge of allergy subject, and then only you should jump to the component testing, which is important. Lung functions and beyond, we understand that spirometry is underutilized. Oscillometry is one test but needs standardization. And then pheno and nasal resistance measurement. So these are just limited to, you can say, like few centers, select centers only. Pharmacotherapy also, we understand inhalers are considered to be the cornerstone. But still, despite that, so many patients who are not on the right inhaler, not on the right dose, not on the correct technique, so which is really very important. Steroid phobia, even among doctors, you and me, steroid phobia is something which is there. So we need to educate ourselves, educate our colleagues, educate everyone. And then allergen immunotherapy, which is important. Nowadays, even allergen immunotherapy, I am sorry with the affair that allergen immunotherapy is misused rapidly with the advent of the Sensimune, which is a standardized immunotherapy, which is uh, approved by the government about 12 years of age for allergic rhinitis. I saw 2 days back a child in which at 7 years of age, Sensimune has been advised and even the person has got and they are taking Sensimune at 7 years of age. So I don't know that what exactly is happening, who is practicing, why they're practicing like that. So everybody is now started, you can say, like practicing irrationally, which is not going to be beneficial and which is not the right direction, which is a sorry state. So, despite the most common allergen, I just spoke about Sensimune or the tablet and the drops. So, standardization is definitely important, but cost also is there. We need to really see. And then coming to biologics. So, biologics, the common biologic which we are using is omalizumab, which is available and which is biosimilar, which is available to us. And then for asthma, we are also having some IL-5 blockers like pembrolizumab, breztrizumab, so the benralizumab. So we are having these, but sometimes we get stuck up in some, you can say, like difficult cases of atopic dermatitis, recurrent anaphylaxis. Then at that time, we require this dupilumab, which is yet not available freely in India. So what we need to understand is that we need to rationalize. We need to rationalize our treatment. The treatment has to be, you can say, like in a step-wise manner, and then the follow-up should be there. Practice algorithms needs to be followed. And can allergy be prevented in India? So yes, definitely we have certain good things like good breastfeeding is there, timely weaning practices are there. We need to strengthen them. Early life interventions are important. Avoid unnecessary food avoidance. And then pollution reduction. Definitely it is important. And prevention is possible, but it is nuanced. So definitely education. Education to the physician, education to the patient, education to the parent, family, everywhere, school, community, children, everywhere education is important. So emergency preparedness is also important. Allergy and mental health, very important scenario in which patient by himself, especially urticaria patients, chronic urticaria patients, their life is like so much disturbed. And the patient is disturbed, he is bugging the doctor again and again, and ultimately the allergist is also disturbed. His mental health is also getting deteriorated. So we need to really strengthen practices for the mental health. So we need to do capacity building in India, and only limited trained allergists right now present. We need to have more and more structured program, diplomas, degrees, fellowships, train the pediatricians, clinicians effectively, and scale nationally. So this is one model which was published in Clinical Experimental Allergy by ourselves. So in which we propose that the education or the target should be at three levels: physician level, paramedical level, and community level. At the physician level, we need to, you can say, like train at different type of trainings. So one physician level could be like the fellows or the students who are new, who are coming up. So they can probably take the regular courses, whereas those who have already been established as practitioners, they have already passed their degrees. Then at that time, contact session based programs would be good enough for them. And then for paramedicals, there need to be some skill enhancement training needs to be done, and ultimately CMEs, workshop, conferences which needs to be there for updatation. Then we need to also ensure quality control. We need to get the facilities recognized by appropriate authorities, and we need to have some participation of the public private sector, which is really very important, and participation of the physician as well as the parent community, initiative, as well as school participation is very very important. And there is role of professional bodies. I am happy that so many professional bodies are now taking initiatives and they all are coming together. So the collaborative platform is really very important. We need to create guidelines. We have created in this year two guidelines from our society. So one is going to be published in food allergy soon, in clinical experimental allergy. Another was going to come on rational allergy practice in Indian pediatrics soon. So advocacy and awareness and unified national voice is needed. So Indian guidelines, I spoke to you about that. So this is an opportunity for India to lead. We have large patient base. We have diverse phenotypes. We have real world evidence and affordable models. So we can actually create something which could be of global relevance. So this is one paper which I published in 2024, in which I have enumerated the problems and then enumerated the solutions, that what could be the solution for us, for lower middle income countries, in which this is actually the summary of the entire session, which I just spoke for last nearly 45-50 minutes. So this is the summary of that. You can just see this paper. This is from Clinical Experimental Allergy, allergy testing in LMICs. So the final message is that allergy in India is real and rising. Indian context must guide care, and education and prevention are key. Collaboration will drive progress, and India can actually lead the global allergy narrative. We have a huge potential. We need to just recognize it, but we need to go with the right steps, which is very important. Thank you.
Thank you so much, sir. I think that was a wonderful session. Uh, any questions in the chat box? No. Any idea when Dupilumab is coming to India?
So Dupilumab is not available, means like formally,
Hmm.
but Dupilumab is marketed by Sanofi
Hmm.
globally. So when I spoke to the division of Sanofi who are dealing with Dupilumab, so they are not very keen in investing because they feel that the market is yet not, you can say, like conducive to them. So we are still trying to, you can say, like push them, but right now they are not okay.
And I think there are a few remibrutinib trials that are going on along. Is there any future of that drug in India? Remibrutinib?
Seems to be, yes,
Yeah.
seems to be, yes. Many JAK inhibitors are now coming, so yes, definitely, Chatir.
Can I ask a
Yeah, yeah.
couple of
Yes,
questions?
please, please.
Yes, sir. Like you said that from Paleolithic era, slowly the helpful microbiota are being hygienically washed away, and that
Yes,
might be a reason for increasing in allergies.
yes.
We are also seeing increase in rheumatic disorders every decade. So, can these have similar like theoretical background
Absolutely,
or link.
absolutely. So we need to really understand that allergy is not something which is, you can say, like out of the box problem. It is something like an autoimmune problem. So
Mm.
all the autoimmune problems, so which are now coming up. So it is, you can say, like rather than the infectious arm, which is Th1, you are getting a non-infectious arm, which is getting predominant more and more. So all the autoimmune problems as well as allergies. Definitely, completely agree with you.
So, sir, like at a young parent level, should we reduce hygiene barriers for the infants? Like it's a scary thing to do, practically
So,
speaking. So,
so that's why,
what is the
that's why,
advice?
that is why I told that now the latest concept is not hygiene hypothesis. The latest concept is targeted hygiene. We need to really understand because we need to make a balance. That's why I told you that when we are becoming allergy specialists, so our aim is not to reduce allergy. Our aim is to achieve or to re-achieve the balance, which is important. So we need to give them a balanced advice. So what I used to do is, like for an example, if you ask me, then suppose if they have to conceive, then at that particular time the counseling, the best counseling is at that time. If they have to conceive, the best counseling, that means that the mother needs to take unrestricted diet if there is no medical contraindication. Suppose if she is suffering from some medical problem and she is advised something, that's a separate story, but majority of the time it is unrestricted diet which needs to be there. There need not to be any restriction. One. Second, they need to, you can say, like whatsoever, even if they are thinking of keeping a pet later on when the child grows, then at that particular time it is better that start keeping the pet during pregnancy, right? Whenever the mother is conceiving, at that particular time, that is the right time to keep the pet. If they have not kept the pet for the initial, you can say, like 1,000 days of baby, that means from conception till 2 years of age, then at that time you should not. Then you should not keep the pet. This is important. Then the third thing which is important is that all the vaccinations of the mother which is needed, iron, folic acid supplementation, vitamin D supplementation, whatever is needed must be done. Thereafter, the pregnancy must be supervised. Thereafter, then if you can curtail pollution from the area of the mother, as I mentioned, the pregnant lady, that will be better. Then thereafter, the delivery, vaginal, breastfeeding, which is important as much as possible, vaccination of the child, routine vaccination of the child, because you need to make a balance. Now, here comes the catch that when you will start the weaning food item in India. So, if the baby is getting exclusive breastfeeding, majority of the time, especially if you just see at your home or my home, then at that time, exclusive breastfeeding becomes difficult up till 6 months of age. But suppose if you are getting exclusive breastfeeding, which is the first choice, then up till 6 months of age, please go ahead, no problem. At 6 months, you must start the allergenic food, do not delay. This is important. Second, suppose if the because of some reason the baby is not on exclusive breastfeeding, then 4 months is the right time. So 4 to 6 months is the weaning time of allergenic food item. All the allergenic food items must be introduced by infancy is over. That means from 4 to 6 months you start introducing, and by 9 or 10 months you must be able to introduce all sorts of allergenic food items whatsoever you want to. Suppose if you want to give non-vegetarian item also, that by 10 months, 11 months you should be able to introduce that also. One item at a time. Okay. So all these things you can just advise them accordingly, but you need to really understand that you need to counsel them that there are so many things which are beyond your control, like genetic changes, epigenetic changes. You cannot really control them, right? So you need to just tell them that these are the preventive steps. There are chances that you will be able to prevent some things, but you cannot give them a definite answer.
Yeah. There are a few questions regarding the availability of AP shot. Is that commercially available now, sir?
No, yet not. Yet not. It is likely to be available in another 1.5 year, 1 year or so. So it will be going for a commercial production. So right now, it is the concept is there. It is means like approved and everything. But I think it will be available by 2027.
Okay. And any news of Neffy coming to India, the nasal epinephrine?
So Nifi, the thing is that this is by ARS Pharma.
Hmm.
So ARS is not marketing. ARS is not licensed to market it outside US. So outside US, this is marketed by this uh, the people who have brought Sensimune. Who is that? I'm just
Dr.
forgetting.
Reddy's.
No, Reddy is in India, but
ALK.
ALK,
ALK.
right. So ALK has got rights for the global rights for the NIFI. So ALK is getting NIFI to all over the countries, all over the world, outside US. But ALK is now planning through Reddy's lab to India. So they are in talking terms. Still don't know.
Okay, because once if nasal epinephrine comes, I think the fear of taking that
Sure, sure, sure,
pen shot also
sure.
reduces.
It is likely to come. It is likely to come.
Okay. Um, any more questions anyone wants to ask?
Yes, I have one or two questions.
Okay.
What about perfumes, sir? Like perfumes cause allergies. Like if they are exposed to perfumes earlier in age, then later on they develop or anything like that.
So you need to understand there is a difference between allergen, and irritant. So they both are triggers, right? So allergen is something which is starting the
Huh,
reaction.
sir.
It needs to be a proteinaceous molecule. It is starting the reaction. It is inducing IgE production, and then later on it is able to bind to IgE and ultimately produces the reaction. Whereas irritant is not starting the reaction. It is just only taking the advantage. I will just give you an example. Like for an example, you are working in a kitchen and you are just taking your, you can say like salt or pepper through your fingers. Your fingers are okay, so nothing will happen. You will be able to touch salt also, pepper also. But on the other hand, if your finger has got a little nick, a little cut, and at that time you touch the salt, now the salt will hurt you. The salt is not hurting. It is the nick or it is the cut which is letting you to be hurted. Same way, if the airway is inflamed, then the perfume and the other things will trouble you because they are irritants. They are not allergens, right? So, but it is always better, always advised not to use them, not to use any strong smell, not even perfume, not to use any strong smell.
Okay. And sir, mosquito coils definitely are problematic. So is the same problem for liquid
Yes.
repellents
Same
and some
problem for liquid
topical?
repellents. Same problem for liquid repellents. Same problem
Same.
for the tablets that tickies, mosquito tickies tablets also. So the best safe is mosquito nets. Mosquito nets are the safest.
Okay, sir. Okay, sir.
So we hope now more pregnant females will go to the villages and stay during their pregnancies and keep a dog with them to have the least amount of allergy risks. Thank you so much, Neeraj sir. And this was a wonderful talk. I think gave our audiences what they needed to know of how India is different in terms of our allergy practices and our problems and solutions. Quite an interesting talk, and I think the future is much bright for the allergy community. And we have ensured that we make you free by 9 o'clock, so you have more 15 more minutes before the next meeting starts.
Thank you. Thank you so
Dr.
much.
Neer,
Thank you.
Dr. Neeraj is a very busy man. You don't want to be in his shoes because he has ensured that there's no respite in the world of pediatric allergy uh, for people who are interested in it. Thank you so much. You are
Thank
an
you.
actual true inspiration to follow. I think he has about 26 or 27 hours every day to ensure that he is able to do all of the work that he's been doing and keep inspiring the younger generation. I think we can learn a lot beyond allergy from you. Thank you so much, sir, for attending.
Thank you. Thank you. Thank you for the invitation. Thank you. Thank you.